Karçaaltıncaba from Hacettepe University. I'll be talking on prostate MRI reporting tips and deep learning algorithms. So we're going to talk about the technique and the zones and the prostatitis and which biopsy methods should be used, and we're going to go over the pitfalls. First of all, you have to be aware that we're talking about a mostly benign disease, although it's known as a cancer, because 85% of the prostate cancer patients do not die because of prostate cancer. It's a localized disease, and you can see these two New England Journal of Medicine articles that describe that you have like 30%, 30 years survival for Gleason 6 tumors, even if you do nothing, just surgery or radiation treatment. So, and we have to be aware that we're going to be doing more and more biopsyless management in the future. I want to show you this prostate MRI, and you can see that this is the apex, and the prostate is coming up, and you can see the tumor right there. It's invading the left seminal vesicle. So I'm going to run it again, and this time, just take a look at the date of the exam. It's 2003. We've been doing prostate MRI more than 20 years. What has changed in the recent years that in the past, radiation oncologists were ordering this study. Now we have the urologists ordering the study. And you have to be aware that the localized tumor, which are T2 and T1 tumors, have a benign course. But if you start having seminal vesicle invasion, extraprostatic extension, or bladder invasion, the prognosis becomes dismal, and we can detect this. And this is our 3D MRI. You can see the anatomy, which is amazing, obtained routinely nowadays. So what kind of a gland is prostate? It's a reverse pyramid gland. I know we're in Egypt right now, so you can see that this is a reverse pyramid. And whenever they do biopsy, they use 12 biopsies, 4 at the base, 4 at the mid, and 4 at the apex. And if you look at the axial lysis, it's like a crescent-shaped moon and a sun, and the sun indicates transitional zone, and the red part indicates the peripheral zone. So whenever a urologist is doing the biopsy, just be aware that they're biopsying less than 50% of the prostate. They always ignore the transitional gland, although we know that 30% of the tumors are arising from here. So this is the message. I mean, even if you do the biopsy, could there be like yellow cancers that can be missed on biopsy? Yes, it is true. And I want to show you this patient. This was a 5mm PAARS 4 lesion, which we biopsied. The 12 quadrant biopsy was Gleason 6, and you can see that this area was Gleason 7 tumor. So this shows you the power of prostate MRI and a fusion biopsy. And the anatomy is very important because it's different in different patients. And sometimes you can see circular shaped peripheral zone. You see squeezed peripheral zone, or you can see different transitional zones. And we have to be aware that there is transitional zone, central zone, and anterior fibromuscular stroma. And I'm going to touch on these. I want to show you two patients with sagittal images, different anterior fibromuscular stroma. This is a hypertrophic fibromuscular stroma, but this is a tumor. So how can we differentiate them? If you look at the axial images, whenever there is a tumor, you can see a lenticular-shaped tumor at the anterior part. But here you see hypertrophic muscle at the anterior part, and you can see the concavity at the posterior aspect. So this is a very useful finding. In addition to that, please look at the post-contrast images and the diffusion-weighted images. If you see vascularity or diffusion restriction at the anterior aspect, this means that there is tumor at that location and you have to do biopsy. And again, in other parts, there was Gleason 6. Only this area was Gleason 7 tumor at the anterior apex. And there is no chance that urologists can detect these tumors. And this is a nice article. And I want to show you another very interesting example. This was a slow flow in the anterior fibromuscular stroma. This is not a tumor. This is a pre-contrast T1 weighted image, and you can see that this is not actually enhancing. And on diffusion, there was no diffusion restriction. Can you see the central zone on ultrasound? No way, you cannot see it. But on MRI and coronal images, you can see the symmetric central zone. What is central zone? It's the parenchyma around the vas deferens. And Interestingly, it can have a inherent diffusion restriction, so it can mimic a tumor, but the symmetry is very important. Please remember this. And I want to show you a very interesting example. You can see the central zone bilaterally, diffusion, there is natural restriction, you can see that. But look at the post-contrast images. In the left central zone, this is indicative of a tumor, and you can report this as a PAARS, and this is from the archive of Dr. Turkbey from NIH and NCI. And why I'm talking about Barış Turkbey, because he was my chief resident like 15 years ago. Now he has an H index over 100, and he has 500 prostate articles, and he was the lead author for the PAARS 2.1. So you can see that he's a prominent Turkish radiologist now working at the NCI. And this is Barış, lovely person. We're proud of him. And you can see that what is PAARS? If you talk about the PAARS 1, the peripheral zone is normal. PAARS 2 means wedge-shaped areas indicative of prostatitis. PAARS 3, if you're not sure if it's a tumor or not, call it PAARS 3. But usually we call it if you have an ADC positive finding but no diffusion finding, or a diffusion finding without a corresponding ADC abnormality. And PAARS 4 means you have the abnormality on the diffusion and ADC images. PAARS 5 means for the peripheral zone it's greater than 15 millimeter. There is a 3+1 indicative of a PAARS 3 lesion. If you see enhancement at that location, then you can make it 3+1 PAARS 4 lesion. How about the transitional zone? It's more difficult. If you see a normal transitional zone or a typical BPH nodule, you call it a PAARS 1. If you see a suspicious nodule, you call it PAARS 2. Again, PAARS 3, you're not sure if it's a PAARS 2 or 4, call it PAARS 3. And PAARS 4 is a lentiform lesion, like you can see it here. And PAARS 5, you can see a big lesion in the left transitional zone here. To see a normal transitional zone is very difficult, only you can see it in young patients. So there is one thing for a transitional zone in the upgraded classification. If you have a PAARS 1 or 2, but if you see diffusion restriction at those locations, you can add 1. So if it's a typical BPH nodule with diffusion restriction, you can make it PAARS 2. If it's a suspicious BPH nodule, you can make it PAARS 3 if there's diffusion restriction. So if you look at the literature, if you see a 2+1 lesion, so meaning suspicious BPH nodule and a diffusion restriction, you can expect 48% tumor in these patients. But if you biopsy them, just remember that over 90% the biopsy result would be negative. So follow-up is indicated in this patient's group. And you can see there are different studies, prostatogram studies. If you have a PAARS 4 and 5 and PSA is over 3, you have to biopsy this. And that's why fusion biopsy is now the standard. So what do you do for a PAARS 4 lesion? The best way is you can do standard plus fusion biopsy. So if you do a combined biopsy, you can detect more definitely, but if you do only targeted, you can miss like 90%. But the good thing is if you use the combined biopsy, you have the fewest upgrade on the gross pathology, like 3%. So that's why we have to do in complex patients the combined biopsy. So you do fusion biopsy and you're not sure to add the 12-core biopsy or not. If you have a PSA about 200 and PSA density about 0.15, you can do only fusion biopsy. If you're doing rebiopsy, PAARS 4 and above, again, you can do just fusion biopsy. If you're doing PAARS 3 plus PSA density lesion, you need to do both. So can we miss prostate cancer on MRI? It's possible. It's 8 to 13% if you have a normal MRI. But the good thing is most of them, almost 66% of these missed lesions are almost benign lesions. Only 1/3 of these missed lesions are higher grade, and it takes 2 or 3 years to these tumors to become ovarian cancers. So why do we miss? Some are very small. Some PAARS is not enough. I'm going to show a case. And sometimes the fusion biopsy is not right. So you have to be aware of these facts. So, and you can see that actually the patients with negative multiparametric MRI undergoing prostatectomy for a tumor they have a good outcome actually. So you have to be aware of this fact too. I want to show you this patient with a PSA 20. Look, the patient had a former transuser resection for BPH, but the prostate gland is abnormal. Actually, this patient's PSMA PET, and you can see there was multiple metastases. So what are the bed tumor indicators? Free PSA, PSA ratio around 10%, PSA velocity of 0.75, very high PSA like hundreds, thousand, a family history, and also PSA density above 0.15. I want to show you this patient, big prostate, 221. The PSA is 27. How you calculate the density? It's very easy, 0.12. And you can see that this patient has a benign course. So you have a negative MRI and you want to avoid biopsy. Be sure that you have a good technical quality PSA below 0.15, young age, and negative DRE. So here comes the technique. You can see that this was an outside MR study. This is our study. Definitely, this is a good study. This is a bad study. And also just remember, deep learning reconstruction is amazing. And you can see the details, the ductules within the peripheral zone. So it's a must technique that you should use if you have it. And also there are other techniques coming up in the literature. So just be aware of transitional zone. It's the most difficult area for PAARS. If you look at this T2, you see nothing, but there is a symmetry area here, which lights up on the PSMA, but this was a proven tumor. Again, a growing lesion in transitional zone, always biopsy, please. And this is an important pitfall. You can see that it looks like a peripheral zone, but it's a protruding BPH, so call it PAARS 2. And also, is this a BPH nodule, suspicious or not? Please remember to look at the sagittal and coronal images. If you look at them, this is not a suspicious BPH nodule. And also, just combine everything you have. This T2, you don't see anything. This is post-contrast. You can see that these areas light up on K-transmap and diffusion. So you need to combine all of these to make the right diagnosis. And also, where you're going to biopsy, it's very important. Just biopsy the very vascular area where you have the most diffusion restriction, because this indicates that there is a very high-grade tumor at that location. Very interesting patient. If you look at this, you might call it a PAARS 3-4 lesion, but if you look at the diffusion, it's bright. Look at the ADC, but here comes the post-contrast. So you can call this PAARS 4, but actually there is no enhancement at the center. This was an abscess within the transitional zone, so it's an important pitfall. And prostatitis it's the greatest mimicker. Just be aware that it can happen in cycling, bicycle cycling patients if they have a pain. And there are ancillary findings. Look at the surgical capsule, peripheral capsule, and we can use advanced methods. This is our article. If you want to read it, published in AJR, it indicates how we can differentiate prostatitis from cancer. Again, bilateral symmetric wedge-shaped enhancement indicative of prostatitis. You can see after treatment, what happens? The PSA drops. Again, another patient, PSA 24, diffuse edematous and pathologic prostate in the peripheral zone, but the PSA density is low, so we use the antibiotic treatment option. So another very important tip, just look at the surgical capsule here. If it's disrupted, it's a tumor. If it's not, just remember it can be a prostatitis. And also, this is a very nice article published in Radiology. You can read this, how you can approach PAARS 3 lesions, PAARS 4, and 5 lesions. So just be remembered to read this article. How about this one? There is volume loss on the right side. Actually, this was a prostatitis. Again, another case of prostatitis in these patients. So if you suspect prostatitis, treat and do a follow-up imaging in 3 to 6 months. Please use diffusion and T2 for the peripheral, for the transitional zone. You're not sure here, but you have 2 tumors in the transitional zone on the diffusion. And again, you look at the tumor capsule and peripheral capsule distance. If it's larger than 10 millimeter, there's high chance of extraprostatic extension. And just remember, we can predict the feature by MRI imaging. So if you have a high PSA scenario, just remember, you can have a high volume. If you have high volume, low PSA density, you have a BPH. In prostatitis, it can be difficult sometimes. But if you have a high PSA, small gland, just remember it can be a tumor. And I want to show you this patient. We were not sure what was going on the T2 or diffusion. We used the K-trans, but there was a left-sided tumor in this patient. So that's why this was a small gland, high PSA patient. New kids on the block, we have micro ultrasounds, and also we can use it for surveillance, just remember that. And here I would like to end my presentation. Thank you for inviting me. Have a nice meeting.
Thank you. Thank you very much. And now we're going to skip the next lecture because Dr. Amr had apologized. And we would like to invite Dr.